Nice Speech Lady. Useful resources for medical SLPs, created by one who is just like you out in the field. Creative, practical, evidence-based resources, building up, learning from one another.
Hello and welcome back to Nice Speech Lady Show. This is Wilson Nice. I'm a medical speech pathologist and owner of Nice Speech Lady. Please check out my website at nicespeechlady.com for resources and handouts and home programs and other information you can use in your clinical practice today. Wanted to start out by sharing a quote with you by Andy Stanley. Direction, not intention, determines destination. Not your intention, but your direction determines destination. This was a quote by Andy Stanley that my father recently sent to me, and it really spoke to me. It's about our direction, not just what we intend to do, that gets us where we want to go. So I wanted to encourage you today on whatever you're working on. Today we've got a great show for you. We have Cheryl Pelletier. She is the owner and inventor of Gnosh, which creates the side biter. And the side biter is a useful chewing tool to work on swallowing and feeding. And it's a new tool that has come out that I wanted to share with everyone and get the word out about this new option for treatment. Before we jump to that though, let me share the screen. And Nice Speech Lady is, like I said, a resource website. Here's the section of the website where you can subscribe. So every time I create a new resource or have an interview or create a news story, you'll get an email in your inbox letting you know to check out the website. And every week I produce something on the website. So please always check back to the website and see what you can find. Today we're going to be talking about my newest resource that I created, which is a packet for addressing impulsivity in cognitive patients. How many patients have we worked with who have cognitive involvements, who struggle with impulsivity? And I've decided to create a resource to have some options for you in breaking down the behaviors so that we can help our patients understand other options that are available with problem behaviors that are impacting safety. So the first part of the resource is kind of the assessment and tracking section. It's kind of your unpacking, you know, what is going on with the impulsive behavior. So naming the behavior and what is the purpose behind the behavior for the patient from the patient's point of view. When common negative outcomes that can come out of the behavior being performed, when it occurs, where it occurs, and then other factors. And then here's a tracking section where the dates of when the behaviors occur can be documented by a caregiver or the patient or by the therapist, describing the behaviors, factors that are at play, what happened right before, and then any other factors. And then this section here looks at behaviors that the patient may themselves feel that they would consider impulsive, and then behaviors that others have identified in the patient that appear to be impulsive and may have potential negative outcomes. And so there's two sections here for naming the behavior, what the patient feels they get out of it, thoughts that they feel, the potential negative outcomes. And then there's a section for alternative actions. What are other options that are available to the patient that could keep them safer and prevent these negative outcomes that they've identified? And so for example, the patient may be impulsively getting up out of their chair when they've been recommended to have assistance when they do a sit-to-stand transfer. And if the patient is in a place where they identify that it's an impulsive behavior and they feel that they're doing it and they're not in a place where they can control it, it's good for us to unpack that and look at their cognitive involvement and see how we can address this. So this section would be for where the patient feels it's impulsive. And then those same items are here for behaviors that maybe others have considered impulsive in the patient, but the patient doesn't yet identify that they understand that there are potential negative outcomes. And so there's 3 sections for those questions there. The next section of the packet is looking at how we can sabotage impulsive behaviors. What can we do to address these impulsive behaviors that impact safety? And this is just a worksheet that you can work on with the patient, working on relaxation, mindfulness activities, calming activities that can help the patient come to a place of equilibrium emotionally so that they're able to focus on not performing the impulsive behaviors. And then other measures to sabotage the problem behaviors. In other words, how can the patient best prevent impulsive behaviors? So there's a section there for the patient to fill out. And then this next part of the packet is a guide that I created for working with patients of what to think about in the moment when they're about to perform the behavior that's being addressed. So this is something that I've used with patients, and we kind of break down if they identify that they want to do something physically to stop themselves, and then decide how they want to proceed before they proceed with the action. And then whatever decision that they've made and how to proceed, that they do it slowly. And this is just kind of like a decision pause, just something that a guide for slowing down this impulsive thinking, and rather than just performing the behavior, stopping and mindfully proceeding with it. And then also those same concepts are here, but it has a space for the patient to maybe fill out what they want to tell themselves in the moment and how they want to proceed slowly in the moment as an alternative behavior. So please check out that resource. I also have the references that make this resource evidence-based here at the end of the resource. So please check out Nice Speech Lady and this new resource that was produced just recently on the website. And now we have Cheryl Pelletier, who's an MS CCC-SLP. She also goes by the nickname of Shasha, and she has been an SLP working for over 30 years with children and adults with feeding and swallowing disorders. She is the creator of the Side Biter Therapeutic Chewing Swallowing System and is the sole owner of her company called Gnosh. Gnosh meaning to chew or to snack. And she's based out of Massachusetts. The Side Biter is a specialized, innovative FDA Class 1 medical device for those with people over the age of 2 who have physical, neurological, and motor sensory food aversions, feeding or swallowing impairments. And she's joined us today for the show. Welcome, Shasha. Thanks for joining us.
Thank you. It's really nice to be here.
Thank you. It's great to finally meet you. We've corresponded some through email and we've set up this interview, so I'm glad we have a chance now to talk. Tell us about your device.
Well, the Side Biter Therapeutic Chewing and Swallowing System is just that. It has 3 parts to it. And initially I was just thinking of one part, which would allow food to gently and gradually come out through some holes for older children with molars and adults. But then I realized that in our therapies, we gradually go from maybe just the motor aspect of mastication and swallowing to introducing food. And then I realized I felt like that a therapist would be able to go through a chewing device or take the patient through a chewing device that had no sensory aspects to the food leaking out except for vision. The visual, it's made to be translucent so that a client could see what was in there and feel it without having the particles or the flavors yet. And then level 2 has 5 holes, and they come across so that they would be lined up with the molars, either upper molars or lower molars this way. And the therapist angled the holes for the inner cheek for sweeping or toward the tongue if there's not a lot of movement, and switch sides as they go, using motivating flavors that you would discover with your patient. And then level 3 would be the 10 holes 5 on the upper molars and 5 on the lower molars. I designed this as a feeding specialist for specific patients that I started to see about 15 years ago. There were more and more older children that were born under a pound, premature children that had feeding tubes, and now they're 12 and they wanted to learn to eat themselves. They cognitively were intact, talking to their parents. I'd like to go have pizza with my friends. But when they would come and talk to me, I kept hearing the same story, just different diagnoses, but stories of, I've never felt food in my mouth. I don't know what to do with it. So that was a really big push for me to be like, okay, we have older children and adults who need a tool that would gradually allow input into the mouth of food to learn oral agility, tongue sweeping, side biting in particular. That's why it's called the side biter. And kind of be talked through it, counseled through it. This is what a Ritz cracker feels like. This is what a pancake is like. This is something that's wet, because they were shocked. So I couldn't really create a tool that had a lot of holes in it, because I felt like there was room for one that didn't have any. And what I really wanted for my toolbox was something that was grippy, something that was durable, and something that stood up so that it would never touch anything and get contaminated. And for our motor delayed or impaired older children and adults, very easy to grab. So I created this for patients that I actually had. And once I realized that it would be something that other clinicians could possibly use, that's when I brought it out.
One of the things I like about the side biter is that you, as an SLP, you have control over what's going in the patient's mouth versus giving them a Ritz cracker or giving them applesauce, because you can pull it back. Is that the whole concept of having the side biter, is that, right, you have control as you start to introduce these things to the patients?
Correct. One thing that I have really, I learn about it every day. I find different strategies to use it with. It's not for all of our patients, but for a certain type of patient, using our clinical judgment. It's been amazing. The big thing that I like about it is that it encourages independence. So it also, I have these easy grips that go on here so that motorically delayed or impaired people can start to bring hand to mouth. So what we know from our work is that your mouth works very differently when you're in control. And as goes the hand, so goes the mouth. So you will see, if you're a feeding therapist, that the minute that something is in somebody's hand, maybe there's more drooling or maybe there's more oral movement. So it's, I really love it as a very independent tool that allows for home support. And like what you said, you can actually control how much food. So the most a patient can actually get out of it is 5 mLs, 1 teaspoon, and that was by design, to not place somebody at risk for aspiration, but give them enough information and practice outside of your therapy room. And that's been huge, especially now that we're doing teletherapy. If I have this on one end of the screen and my patient has a level 2 on the other side, I can guide them through moving it different places in the mouth, doing some elevation, doing lots of different things. It has a lot of different opportunities for growth. The other thing that I really like about it is when I was working with a designer, I wanted it one piece. I did not want it to come apart at all. I did not want anybody to be able to pop it off. And the the idea is not to stay on these very long, just to get to solid foods faster, safer, more successfully, and then obviously do food. That's the goal. Eat safely.
Kind of like the transition between no solid food to transitioning without it. Let me ask you, you mentioned that it's not for every patient, but it's for a specific kind of patient. What would you say would be the qualities that you would find in a patient that would be ideal for the side biter?
That's a very good question. The very first thing I would say is somebody that's very motivated to chew. I've used it with ages 2 to probably 92. And I feel like when you meet a patient that, the profile is they chew everything, but they don't chew food, or they need to chew sensory-wise, but they haven't gotten beyond purees. Those patients, whether they have developmental delay from birth, autism, Down syndrome, post-stroke, seizure disorder, cerebral palsy, I find that those diagnoses have been the ones that have really benefited from that. There have been older patients that are moving from a home environment to a group home environment, and they've had regression in their eating, and the staff is upset and they don't know really what they can do. It's been very helpful to use the biter system to get them back chewing, introduce some food safely, teach some concepts, let them practice, and I've had great success even weaning from G-tubes with this system. Some patients just go to one level. I can see that they would be appropriate for level 3, which has 10 holes, and they just go from there. I've had families, moms, reach out to me and send me videos of their 7 and 8-year-old children who have cerebral palsy, who love the smell of sausage, for example, or but need to be pureed all the time. But if it was cut in strips and placed inside the biter and guided through, they, under their own power, they make it into a pulverized consistency, and a little bit leaks out at a time. It's designed to be used with a feeding therapist, and then if that feeding therapist, feeding and swallowing therapist feels that they can home, then they would create a home program for them. But those are the patients. Post-stroke has been really big. Waking up from a coma after COVID, having a stroke, can't do anything, using level 1 with no holes just to put some juice flavors and juices on it and actually see a food inside. One gentleman in his 30s had a brain injury, reached out to me after using it, and his wife put pizza, his favorite food, inside and then just did the juice so he could actually see it instead of just a tube with nothing, just a tube. And then gradually they put pureed pizza on it, but the whole pizza inside, and then gradually went through the levels, and just it motivated him to actually use the muscles more, get more food out. And it was what he looked forward to when in his rehab. So I get these, stories all the time. So I feel like that it's something in a toolbox that a lot of our clinicians could actually use.
I'm so glad you created it. Tell me what steps you took, other than what you've already said, and anything else you want to share with us that you did to create this tool. I mean, to invent a device is quite an undertaking.
It actually was. It started about 15 years ago. Anytime I went to ASHA or any conferences related to feeding and swallowing, I would, of course, buy tools and, ask the experts in the field, what do you do when you have a 12-year-old that's never eaten before? What tools do you use? And, what do you do if their child is 2 and has all their molars and, wants to eat, but really can't? And I just found more and more that there was a need for something like this. And I would ask clinicians if there was something like this that I described, I would draw it and they'd be like, yeah, I would definitely try that out. So I started doing some research. I started doing a lot of drawings. I used silicone straws with holes in them for years. I folded them. I taped the end. I just manufactured my own little side biter, and I was having success with it. Not very safe because you can't really send it home. So I started to research companies, silicone companies, not knowing, what do you do? So I did find a silicone company in upstate New York who manufactures baby bottles and breast shields, and baby bottle nipples, pacifiers, and breast shields. They helped me find different engineers, which is a long story, trying to find an engineer to take you seriously when you're saying, I need something that looks like this that you chew on. And most of the engineers locally in the Boston area, all of them, I would have to say, were like, we're not interested. A lot of them laughed at me, which I was a little bit hurt, but I got over it. I did find somebody that listened to me and came up with a 3D schematic of a device, and we went through prototypes. We went through 6 or 7 prototypes in the last 10 years. And it was originally 3 parts, and it had the handle and then 3 tips. And I didn't like that idea because I was worried that somebody with dementia or somebody who's very strong would pop it off. So we came up with this. This is the drool guard, so that, because obviously a lot of drool comes out and a lot of our patients don't like things on their hands. So this is eventually, after years, this is what we came up with. And it also was more cost effective because what I learned is that to create each part, you have to have a designer make a mold. A mold maker has to make a mold for these out of aluminum or steel. And then it goes to the manufacturer. Each mold was over $30,000 to make. So if I had 3 of them, do the math on that one, it was very, very difficult. So anyways, 2 parts, it worked out great. They had problems creating the holes. That took a year.
Wow.
But I found some really great people to work with. They believed in it because I was so excited about it, and I was chewing on the prototypes and putting all kinds of food in. And so I chewed on it for years, and I would find a new food. Like, well, I wonder how scallops would work. I wonder, and I would think, if I worked with somebody, I would say, okay, thin liquids through this is not going to be good for you. We need to make sure we use things like mac and cheese or something that's not thin. So you have to use clinical judgment to figure out what to put in here. So a lot of barriers. One barrier was that the engineer listened to me and because I said, I want all the food to stay in the tip. I don't want any food in the handle at all because I want to be able to write in my note. Johnny was able to masticate and side bite on both sides and suck and lick and transfer 5 mLs safely without symptoms of aspiration. So I felt like also with documentation, I needed to have something other than, Mr. Jones was able to eat a chickpea-sized piece of something. I wanted to measure it. So anyway, the engineer listened to me. He made this very tight, but the manufacturer and the mold maker felt that the inside was too tight. And because I'm a speech therapist and not knowing anything, they made it a certain way, and it didn't work. It moved around, and as soon as I took a bite of something, it shot out the end. So back to the drawing board.
Yeah.
When clinicians get their biter system, they will notice that it kind of is like this on purpose. because the only way to keep it tight inside, this is related to the manufacturing and what we went through design-wise, it has to be wet either with food juice, or my favorite weapon is vegetable oil or canola oil, because it makes this move, this plunger move very nicely, and it locks. It locks so that when you chew on it, if there's 5 mLs or a little bit, maybe less, the food doesn't shoot out of the end. And yes, there are some juices that sometimes come out if you're using a juicy food. However, we can get over that. It doesn't touch a hand. It might come out here and you can wipe it, but the actual device, it's not to stay on for a long time. It's designed to just get to the food, eating it safely. So the other barrier that happened was COVID. At the time that I was trying to get, 5,000 of these created, COVID was starting to ramp up, unbeknownst to us, but silicone companies were under pressure to get more and more silicone tubing and, excuse me, for medical devices. So, excuse me, getting this FDA approved mouth-safe silicone became an issue, and it became extremely expensive, and I did not want to go overseas for it. So that was a little bit of a barrier, kind of a lot of a barrier. So muddled through, used my time that the silicone wasn't available to get it FDA registered. So it was FDA registered. When the concept first came out, I did put a patent in with the patent office. It is, so that was several years ago. I learned a lot. It takes 2 to 3 years to get a patent actually in your hand. And it takes over $15,000 to create a patent with the lawyers and that kind of thing. So it wasn't like I had that. I had to go slowly with finances. I couldn't just boom, do it all at once. So that's why it took about 10 years to do. Wow. And it's been very worth it. It came out right during COVID closures where we couldn't really see face-to-face patients. So I was able to utilize it in teletherapy, and that was amazing. And I kept realizing different ways that it could have a role in our field. And home programs, school-based programs, group homes, skilled nursing facilities, and teletherapy have been really settings that it's been valuable in.
So you've been through this journey for years of creating this device. Who is your support? Who do you have in your life that's been cheering you on through all of this?
Well, I would say that my family, some background a little bit is that my middle brother, has a traumatic head injury. And it happened when I was just starting speech therapy school. And he was in a coma for some time, and he had problems with everything, eating, walking, everything. Back then, I didn't know what I know now. And I used to try to help him eat. And I was struck by how he couldn't move his tongue. And if he moved his tongue, he couldn't swallow. And I was very interested in that. So fast forward, he's doing quite well. My mother is a nurse. And they've always been my cheerleaders behind the scenes. I have a very supportive husband who has helped a lot. We pooled our resources to try to make this happen in a decade of work. I have 2 wonderful daughters. One is a speech pathologist who is not a feeding specialist, but is really an inspiration to me. And my youngest daughter is a dietitian. And she's heard many stories of getting the dietitian involved, and we need GI, and we need nutritional support. So I like to think that my whole support system understands why this would be important. and have always been like, Mom, go, go Shasha, because every time somebody uses it, they tell me it's amazing. I've never gotten one person that said to me, this doesn't work, or it's a choking hazard, or everyone says it's excellent. I can't believe you invented it. And when I say it's not for all people, it's not like you get a feeding case and you're like, oh, out comes the side biter. That's not what it's for. It's for clinically advanced clinicians who make a judgment about what types of tools that they could use with the patient. Occupational therapists absolutely love it. They use it. Their goals are a little bit different. They're trying to get hand to mouth, and they're trying to get some oral sensory skills going, whether it's dipping it in a food or putting ground food inside. So the feedback from dietitians, occupational therapists, and speech pathologists has been really great.
So speaking of professionals, so those are the professionals that use the side biter. Other than SLPs, who all could use it?
So with training from a clinician, I've allowed staff at a group home or nurses or aides in a skilled nursing facility to use it for certain textures. I give them a list of types of foods that would be ideal. Family members, home nurses. I have several children that have 24-hour nursing, and so I would really trust them to know when to stop. I give a time frame, use it for 5 minutes, 3 times a day. So it's within guidance of a clinician. I also just thought of something I wanted to also tell you who supported me was Lori Overland. So Lori Overland is a speech pathologist, feeding and swallowing specialist. And when I first got the concept, I called her, and I had met her at conferences, and I said, please tell me now if this is a dumb idea, because it's going to be really a lot of hardship to do this. And she said, nope, Shasha, absolutely. And so I have bounced things off of her for years. And she's been unbelievably patient and a wonderful advocate. She features it in some of her classes, which I really appreciate, because I don't have a marketing team. I basically have me and my daughters who are savvy on the computer. Right. So if that's that.
Well, let me ask you, in wrapping up our interview, I'm so glad we had a chance to talk today, and I'm so excited to try this and get my hands on this tool and be able to experience what you're describing as some outcomes that could come out of this. What is the main thing you want listeners and readers to know about the side biter?
I want them to know that it was created by somebody that actually needed it in their toolbox, and it's not anything to make money with. It's basically the more people that we could help. I think back to some of those clients I was telling you about, and I felt like I couldn't help them as much as I wanted to, because I couldn't even get past taste in the mouth. Mm-hmm. We tried, and I mean, we got a little ways, but I felt like back then, if I had a gradual system of that would introduce little bits in the food in the mouth when a person was masticating and actually learning to move their tongue and jaw and activating a swallow on time, I feel like I could have helped a lot more people. So I want them to I want people to know to have an open mind and to chew on it themselves. I know that sounds crazy, but if you boil it for 10 minutes, do it yourself. So it's not supposed to really go in this way. It's supposed to go in this way along the ridges of the molars. And I want people to know that the tool was designed for across the lifespan, because there's so many tools out there that we use that are used for children under 6 months, or just 6 months, or 6 to 9 months, or, you know, something for an adult that you chew on that has no food related to it. So that's what I want people to get out of it. That it's not from a large company. It's for helping patients that don't have tools available to us right now.
Yeah.
I hope that was helpful.
Yes. That speaks to your heart, the heart behind, you know, why you are doing all of this, and that you've used it with your patients. ASHA 20 is your code to get 20% off, I understand, right?
Yes, so I'm getting ready to go to ASHA. It's hybrid this year, as many people know. So I am making the drive to Washington, D.C. I'm going to be an exhibitor. And we have the 20% off coupon, ASHA 20, now through the end of November, to let people give it a try. My prices are as low as really I can go at the moment, just with shipping and supply. And I always give away, for my own patients, I give away these. I don't charge any patient. If patients reach out to me or families reach out to me, I've given away over 850 of these. And again, it's for really helping people. It's not, I mean, I work full time. I'm a company of one. It's something that I've found that I feel for certain patients, if traditional techniques aren't moving them fast enough, I think that it's worth a try in our toolbox.
Awesome. So listeners, you can go to www.sidebiter.com, and you also have a Facebook page and an Instagram. So please just check out what Sasha has. And thank you so much for coming on the show today and sharing with us about the Sidebiter.
Yeah, I'm available if people want to reach out to me.
Yes, how can they reach you?
Well, on my website, they can email me right through the website,
okay,
or my phone number is on my website. So I get calls and emails every day. I'm happy to do training. I don't charge anything. I just explain what possibly could occur with specific patients, and that's that. I really appreciate this platform.
Thank you. Thank you so much for joining me. And again, reach out to www.sidebiter.com to learn all about the Sidebiter. And thanks again, Sasha, for joining me today. Thank you for your time.
Thank you for having me.
And that's it for the Nice Speech Lady show today. Thanks to Cheryl Pelletier for joining us. Wanted to ask you to please check out the SLP Support and Nice Speech Lady Facebook group, where all of my posts are from the website are shared on social media. There's also a Nice Speech Lady Facebook page. Please check us out on Twitter and on Instagram. And at the same time, please just go to the website and peruse all of the resources that are available to you. And wanted to remind you again, direction, not intention, determines destination. So as you're making your decisions this week and how to proceed with your life goals, I want to encourage you. I want to tell you that you're doing a great job, and I'm proud of you being in this profession, and thank you for doing what you do every day. And wanted to thank everyone for joining us. Thanks again. Please come back and have a great day. Bye-bye.